In this episode of the Nurse Practitioner Podcast, Megan Danielle Atchley discusses acute febrile illness in children during the COVID-19 pandemic. What is the appropriate temperature measurement in children?
So that is a great question, especially in the day of COVID-19, because as you know, a lot of places that are public are having us screen in. And so usually what you see when you screen in is going to be that non-contact infrared forehead thermometer. So the question is that actually reliable? Well, if we are looking at temperature measurements, if you have a child presenting to your clinic or the emergency department, and they're under the age of 3, the most appropriate temperature measurement for that child is actually going to be rectal. However, there's going to be certain situations that you need to think about other measurements. So if we look at the literature, those appropriate measurements that we should consider, let's say, for instance, you have a child coming into your primary care clinic, or they're reporting to an urgent care clinic, and they're well appearing and they're presenting with an orthopedic incident or a trauma. At that point, one of the temperature measurements that you should use would likely be axillary, and that's going to be appropriate in that situation. Now, let's say, for instance, you are just having routine screenings like we were talking about to those public places, your school, your church gatherings, parks, any type of event that's closed indoors, and we need a screening measurement that's comfortable, that's rapid. Then research shows in that situation that non-contact infrared forehead thermometer is appropriate. However, again, if you have an acute febrile illness and the child is less than 3 and you want an accurate temperature and they are not well appearing, the most accurate and appropriate temperature measurement is going to be the rectal route.
What are some common clinical presentations of fever in children?
Well, some of the common clinical presentations of fever in children that you will see presenting to a primary care clinic will be things such as irritability. You might also see what we call tachypnea or increased respiratory rate, tachycardia, which is the increased heart rate. Other things that you should be noticing is this a respiratory presenting type clinical fever presentation? So are they having that increased respiratory rate with wheezing? Do you see retractions? What about the nasal flaring? So if those are presenting to you when you're doing your assessment piece, then you're automatically starting to think differential diagnoses related to respiratory condition, right? But also a lot of times febrile presentations can also consist of parents reporting to you that they've had diarrhea. So if they've had GI upset and those types of symptoms being reported, then you should start thinking about gastroenteritis. Another diagnosis that you should start to consider is if the parent reports to you within that clinical presentation and history, foul-smelling urine. Well, urinary tract infection could be something that should be considered because this is prominent within that age group of pediatrics presenting with acute febrile illness. Now, if the patient is presenting to you with a fever report from the parent, other things that you should be worried about is, are they lethargic? Have they presented with any listlessness? What's their appearance like? Do they seem toxic, or are they happy, consolable? Not only that, but how do they respond to any noxious stimuli? So if you're talking to the child and you're making faces with them, a lot of us will smile, do what we can to see how they'll react. Is it a positive reaction or is it negative? Other things that you should take notice of is, how's their appearance? Is it mottled? Do they have any pallor? Is there any cyanosis? And beyond that, let's say that they're less than 11 months of age. Then you need to be assessing for that fontanelle. Have you noticed any rashes? And if you did notice rashes, are they non-blanching? Any petechia? Any rigors or leg pain? Now, leg pain, of course, would be something that the patient would report if they're talking and communicating at that age. And of course, we talk about our red flags of concerns. So red flags of concern would consist of anything that you notice, like the toxic appearance, the lethargy, the listlessness, if they're in respiratory distress, if you did notice that petechia type rash, if they're inconsolable. And anytime that you have a pediatric patient presenting to you with an age less than 1 month, you should be concerned with a high fever. That's when we start looking for those really serious bacterial infections because they're immunocompromised because they haven't received those vaccinations that are appropriate for their age group.
What are the most common differential diagnoses to consider for children presenting with acute febrile illnesses?
So when a pediatric patient is less than 3 months of age and they're presenting with a fever, a thorough workup should be completed. And we've got to consider whether or not they've received those age-appropriate vaccinations. So if they're the age of birth to 2 months, per the Centers for Disease Control and Prevention, those vaccinations would be Hep B, 2 doses, the rotavirus, DTaP, Hib. You've got your pneumococcal 13, and they would have 1 dose of each of those. So let's say you have this neonate present to you and they're less than 28 days and they have a 102.3 fever. At that age, they're considered functionally immunocompromised. Fever in this patient is serious and they're going to be at a higher risk for invasive bacterial infections. So we're very concerned with this age, and so we would need to do a thorough workup, and that would be considered looking at blood cultures and spinal taps. Beyond that, what we would look at is diagnoses such as bacteremia and sepsis, pneumonia, sinusitis, meningitis, and urinary tract infections. And some of the other common acute febrile, viral, and bacterial illnesses that present to our outpatient primary care clinics are ear infections, strep throat, during this current season, influenza, gastroenteritis, croup, bronchiolitis, or what we know as RSV, and viral colds. So in order to differentiate from the more serious febrile bacterial illnesses from the acute febrile illnesses that can be managed within primary care, that goes back to that clinical presentation and making sure that we're obtaining a thorough history and clinical examination. And then also, we need to make sure that we get those important vitals like we discussed. We need to make sure we get a temperature, respiratory rate, heart rate, and even oxygen saturations, especially in the child that's presenting with respiratory symptoms. And we're going to check blood pressure as well, because we need to make sure that there's no concern for sepsis in that child that's presenting with acute fever.
What are acute fever treatments in children?
So again, it's going to be essential to determine the cause of the acute fever with that pediatric patient, because that's going to determine how you're going to formulate your management and treatment plan. So for the febrile pediatric patient less than 3 months of age, as we already stated, who appears very ill, we've got to obtain a urinalysis. That's going to help us rule out a urinary tract infection. We need to get that complete blood count and blood culture to see if there's any type of bacteria that we need to treat. Now, a chest x-ray should be obtained with any signs of respiratory illness, and a stool culture if diarrhea is being reported or if we observe it. Now, in cases of uncomplicated bronchiolitis, a chest x-ray can be omitted. If the patient, again, is ill appearing and they're less than 1 month, like the example I gave of the 28-day-old, then a lumbar puncture is suggested with cultures, and then our treatment will be based off of those findings. But let's just say we had an uncomplicated case, and it seems that this could be a viral presentation. Treatment for fever in pediatrics is oftentimes completed conservatively with pediatric dose adjustments for acetaminophen and ibuprofen. So for acetaminophen, the dosage is going to be 15 milligrams per kilogram per dose, and we can give that orally or rectally every 4 to 6 hours. Now, ibuprofen can be given orally every 6 to 8 hours, and we're going to dose that at 10 milligrams per kilogram per dose. Now, a good reminder for everyone is that only infants and children greater than 6 months of age can receive ibuprofen. Sometimes parents, they seem to forget that even though it might be over the counter, it's not going to be as safe for children unless they're older than 6 months. So we really need to make sure we're educating our parents on that. Tepid and cold sponging and baths, they're not really recommended. Even though this has been seen a lot in practice, what we have found out is that this could lead to further distress for the child. And what happens is if you're distressing the child more, they're getting more irritable. Well, what does that do? That's going to burn off more energy, burn up more calories. And if it's a child that's already having this increased demand and needs more calories because they're not eating a lot, that's something we want to stay away from. We want to alternate acetaminophen and ibuprofen only in the cases of they're not having that fever break by the time the next dose of a medication is due. So what do I mean by that? Well, let's say you gave ibuprofen and they're due for ibuprofen, but they have another 2 hours before they can take it. And they still have a fever and it's 101 and they're irritable. In that case, you can go ahead and give them acetaminophen. However, we generally recommend not doing that because of the concern of an adverse event if the parent got confused, gave it too soon, or accidentally double dosed on ibuprofen. So a lot of times we recommend against that, or what we can do is have them write a schedule and have them chart, almost like we did when we were on the floor in nursing, is chart when they gave it and cross it off and make sure they're keeping up with the times if they need to alternate it. Again, both acetaminophen and ibuprofen, they're considered safe options for fever treatment if used appropriately. However, if a child hasn't had acetaminophen and ibuprofen before, just remind the parents to watch for any type of allergic reactions for first-time use and remind them that they need to give the appropriate dosage because we know excess dosage and inappropriate amounts can lead to hepatic injury with acetaminophen and gastrointestinal bleeding and acute kidney injury with too much ibuprofen use. Lastly, it's not recommended to undress a child or overdress a child, as this can lead to shivering and overheating. And like I said before, those are activities we don't want to do because that can lead to a rise in the consumption of their energy and catabolic needs.
How does COVID-19 present in children?
So to address this question, what I did is I also pulled a lot of the literature to see what the studies are showing for the different presentations, or I would say the overall presentation of how COVID-19 is presenting in children versus just what we have seen in practice. So what I've found out is that it's a lot of asymptomatic presentations. And so when we say asymptomatic, the studies that I've found, 3 different studies of looking at different populations of patients diagnosed with COVID-19 pediatrics, and it was 4% of that case presentation was either asymptomatic, which means no symptoms at all with a positive swab, or 9% of the case presentation they looked at was asymptomatic, no symptoms with a positive swab. However, in summarizing the findings from the literature review and then also from what I've observed, 60% or over 50% of these pediatric patients that have tested positive usually presented with fever. And one of the studies showed that 60% had a cough, 15% had diarrhea with nasal discharge. Less commonly observed symptoms we've seen is vomiting, tachypnea, a sore throat, and fatigue. One study I found, their laboratory findings showed 80% had elevations in procalcitonin, while in 70% of cases, white blood cells were normal, and creatinine kinase was elevated in 75%, with CRP increasing in 45% of those positive pediatric cases. Interesting, they go on to report that with those patients, they did CT scans, and in 50% of those patients who were positive, they presented with bilateral pulmonary lesions on CT. So again, as you can see, in a large majority of pediatric patient populations, we're seeing that asymptomatic presentation where they're carriers. And so we've heard a lot about this, we've seen it in the literature, and we've had presentations to clinic of that. And you're wondering, how do you have presentations of clinic to that, and how are they ever tested? Well, what the literature has shown is that you have groups of families who may end up positive, say, for instance, the parents. So the parents are positive and they have symptoms. And so the next step would be the parents want to have the child tested, even though the child has no symptoms. So then they have the child tested and the child ends up being positive, even though the child has no symptoms. And so that's what we call an asymptomatic case. And so again, in the last study I reviewed, they observed 34 pediatric patients. And with those patients, 65% had respiratory symptoms and 26% had mild disease with fever, with cough being reported in 38% of those cases.
This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer.